Commission will hear a panel presentation and discuss the use of data as a lever for transformational change. Before I turn it over to staff to introduce the panelists, let me say how excited I am that we are having this discussion on data. In the education field, data is fundamental to how we monitor, track, and trend our students and review the trends our students are demonstrating. When we pay attention to how our students are doing, what their educational outcomes are, we can then make good decisions about how to support our teachers, our school staff at every level, and how we can support our districts. I'm thrilled that we are going to hear more today about the opportunities data can offer toward increased accountability for our mental health system. I'd now like to pass it over to Commission's Chief of Research and Evaluation, Melissa Martin-Mollard, to introduce the topic and our esteemed panelists.
Thank you, Madam Chairman Weiss. Is my audio okay or am I echoey?
I like it because you said my name and it sounded like I was in a big auditorium. Like, I'm teasing. Yes, there's something going on with audio. So let us fix that and see what it is, because there's an echo.
Okay, how is that?
That's better. I'm no longer in the stadium.
Okay, great. Good morning, everyone. The purpose of today's agenda item on data and metrics is to discuss some of the opportunities and challenges related to using data for decision-making, transparency, and accountability, with an emphasis on accountability for public systems. Each of the panelists today will share their unique and specific perspective on using data for public governance. After the presentations, we will open it up for commissioners to ask questions and have a discussion with the panel. Then, of course, we will open it up to public comment. I'm pleased to present the panelists for today's session on data and metrics, starting with Dr. Emily Putnam-Horstein. Dr. Putnam-Horstein is the John A. Tate Distinguished Professor for Children in Need at the University of North Carolina, Chapel Hill, and the faculty co-director of the Children's Data Network. Dr. Putnam-Horstein's current research focuses on the application of epidemiological methods to improve the prevention of non-fatal and fatal child abuse and neglect. Her analysis of large-scale linked administrative data has provided insight into where scarce resources may be most effectively targeted, and informs understanding of maltreated children within a broader population-based context. I'll now turn it over to Dr. Putnam-Horstein.
Perfect. Thanks so much. Let me just make oh, did you want me to I was going to share my slides, or do we want to do it this way?
Either way.
I'll
stop sharing.
Okay, perfect. Thanks. Just 1 second. I think I'm all set up here. Almost all set up here. Not all set up here. Perfect. Sorry about that. I just want to thank you for the opportunity to speak today. And before I dive in, I also want to just say that I am a member of the Brian Salas fan club. So it was fun to be on this morning and hear him honored. I can't even remember when I first met him, but he has been such a leader across so many different agencies. And I want to kind of channel what he was really reinforcing, which is the potential to use data to promote transparency and accountability in our public systems and for the people of California. So as you heard from Melissa, Emily Putnam-Horstein, I've had the privilege of working closely with a number of different state departments in California going back almost 2 decades. And so I'm going to keep my remarks very brief this morning, but what I'm going to do is present 4 just examples of how data have been used to generate new insights, drive important policy and practice conversations. And I will close with an example where I hope to reinforce that I also think we don't need to rely on data that is retrospective, but can increasingly bring more data to bear in our daily decision making in a way that will serve children and families and all individuals in California. I will also say that because almost all of my research is very focused on the child protection system, you will not be surprised that my examples do focus on child welfare, but I have tried to bring a mental health lens to those examples and select them based on that. So I will go ahead and get started. Just very briefly, the Children's Data Network is a project housed at the University of Southern California in partnership with the California Child Welfare Indicators Project at UC Berkeley and the School of Social Work at UNC, where I now am. And for the last 10 years, we've been working closely to demonstrate that there's a lot one can learn from individual data systems that serve children and families, but that much more that one can learn when you connect those different data systems. And so the examples that I will present emerge from a multi-year effort where we have been partnering with the California Health and Human Services Agency to carry out what we affectionately call a record reconciliation. We probably should have come up with a more exciting name for it, but what that looks like is that starting back in 2018, we have had an agreement whereby the departments within HHS have sent us a census of all the clients that they have served in that calendar year. And we have used probabilistic algorithms to match up those clients so that we can see how many clients, for example, had an open child welfare case and were also receiving developmental service supports. This is the trajectory in terms of the different records that have been included. And I'm happy to report that we are partnering closely with the Center for Data Insights and Innovation within CHHS to transfer back to them a lot of this linkage work. So we treated this as very much a demonstration project of what's possible when we create kind of that huge Venn diagram that helps us understand the different public benefit and systems that individual clients are interacting with. And we will now be kind of returning to the state everything that they would need to carry this forward. So that takes me to kind of the first example that I will provide, which is a very, very simple one. But the question we were seeking to kind of address was simply, what is the overlap of children across some of our major public benefit programs? These data that I'm presenting here reflect all children who were receiving benefits or services from each of the programs listed on the x-axis. The data are from 2017. We've continued to update it annually, but I'm just showing this for more illustrative purposes than anything else. And all we did was look to see how many children who were interacting with one particular program were also receiving services from others. And so I want to draw your attention to that fourth bar where it's labeled child welfare. And what you will see is we were able to look at all children in California who had an open child welfare case for services in 2017. That meant they were either receiving kind of court-ordered services in the home, or they had been removed and placed in foster care. And what you will notice about that bar is the portion that is the kind of the bright turquoise is much larger than any of the other bars. And that's because nearly a third of children who had an open child welfare case were receiving services or were kind of eligible for services from at least 5 other CHHS programs. And you can contrast that with some of the other bars. But what did this provoke? Well, it really provoked kind of an appreciation that care coordination is incredibly important for this population, both because they likely have higher needs, but it was also a reminder that while we tend to think about programs in very siloed fashions, a whole bunch of programs and departments within CHHS were serving a population of children who they thought of as child welfare, but were also their children. The second example is an example where what we did is we were able to link up Medicaid or Medi-Cal records for children throughout the state and try to answer a question as to how many of those children both had a diagnosed mental health disorder and how many of those children had some child protection or child welfare involvement. So this study involves all children in the state who were Medicaid eligible for at least 1 month in 2014 and 2015. We were then able to look at their kind of claims to identify all those who had a mental health diagnosis. And then using those linked records that we'd been working with the state on, we were able to document how many of those children with a mental health diagnosis had some involvement with the child protection system, either currently or in the past. So we were going all the way back to the late 90s to look at this. And I want to kind of call your attention to a few things. First of all, what's not shown on this chart is that fully 50% of kids with a mental health diagnosis in our state had some level of CPS involvement. 50%. In contrast, for children who were Medi-Cal eligible and had no mental health diagnosis, that number was 23%. So a really, really striking difference between Medicaid eligible kids with a mental health diagnosis versus without. But what you will see here is there was also tremendous variability in terms of the likelihood or the proportion or percentage of children who had a mental health diagnosis and had CPS involvement. So this chart shows that, for example, at the very top, for children who had been diagnosed with bipolar disorder, 75% had had child welfare involvement. At the other end of the distribution would be learning disorders, where it was 29%. But I think really importantly, it's a very large number overall. And what you will see that I have highlighted in the kind of text I've pulled from this paper is I think it's really important that we remember that the vast majority of children who have mental health disorders and have child welfare involvement never end up in foster care. In this population, it was 87% of these kids we were looking at were remaining at home, which is great. But then the question is, how are we ensuring that we've coordinated the proper array of services for both their mental health needs and anything that may have given rise to child protection involvement? So that is example number 2. Example number 3 is another paper where what we were doing here was trying to take a look at how much there was a discrepancy between what we kind of are maintaining in one case management system versus another. And I think this speaks to the importance of continuing to link data as opposed to simply thinking that if we add more fields to our existing data systems, we'll get the information that we need. And so in a nutshell, what we did is we simply looked in the child welfare data from California and said, if we treated that data as accurate when it comes to a kind of mental health diagnosis, which in the official files is called an emotional disturbance. I realize that's not ideal language, but that's the language that's used in the AFCARS files. And if we simply looked in the child welfare data, we would go to our legislature, we would enter into policy discussions claiming that 13% of children in foster care have some kind of mental health diagnosis. But when we actually link up those children who are in foster care to their Medicaid records, what we see is that 13% is a huge underestimate. We found that almost half of children in foster care had a mental health diagnosis. And so I share this because there was kind of national congressional testimony that was given, not just about California, but about all sorts of states that in some ways really misrepresented the extent to which mental health challenges and concerns and supports were needed, because they relied simply on one data system as opposed to looking at the data system that really is the source information, which would be coming from that which provides mental health and healthcare services. And then my final example before I turn it over to the next panelist is one where I want to kind of just reinforce that. What did I show you? I showed you some data from 2014, 15, 2017. I showed you data from years ago because that's what researchers do. They wait for data to become available. They come up with an analysis they want to run. They write a paper, and then they hope that a handful of policymakers and others will read the paper and that there will be translation and there will be impact. But increasingly, we do not need to do that. There are ways that data can be harvested in real time and used to improve practice. And so this is an example where I will not walk you through the full picture, but what I want to reinforce here is that in our child protection system, we make a series of decisions from left to right. Calls come into the hotline. We're making a decision about whether we investigate or not. And what we have been doing in partnership with Los Angeles County is to start harvesting information from the case management system in real time so that supervisors are presented with information as to the kind of risk and protective factors that may be operating so that they can better tailor and target their time to make sure that they are connecting children and families with preventative resources and interventions when warranted. And so I just want to kind of reinforce that I think there are tremendous opportunities to continue to promote accountability and transparency through linked data, through administrative data. But I also think that there are real opportunities to start thinking about very kind of cost-effective tools that can be used as overlays to our case management systems so that we are helping frontline staff do a much better job serving children, families, and others throughout the state. Thank you so much.
Thank you so much, Dr. Putnam-Horstein. Our next panelist is Daniel Webster, who serves as the principal investigator of the California Child Welfare Indicators Project, which carries out quarterly production, dissemination, and technical assistance on performance measures in support of the state's outcomes and accountability system. Dr. Webster has provided consultation to child welfare agencies in jurisdictions across the country on understanding and applying longitudinal data to promote continuous quality improvement, and has co-instructed courses with colleagues from Chapin Hall at the University of Chicago on advanced analytics for child welfare administrators. So I will now turn it over to you, Dr. Webster.
Thanks, Melissa. Can you hear me okay? I just want to do a sound check. Great.
Yep.
We're not in the stadium. Okay, great. And thank you to the members of the commission for giving me the opportunity to speak with you today. It's always great to go after Emily. Those are tremendous examples that Emily gave. I'm going to share my screen and bear with me. Share. And I'm going to I'm going to take a step back and talk about my experience working with the Child Welfare Indicators Project and give the Commission my thoughts on key foundational pieces for ongoing use of data in the use of system accountability and transparency. And this is based on my, as Melissa was saying, 20 plus years of experience working with the Child Welfare Indicators Project at UC Berkeley in partnership with the State Department of Social Services. We get quarterly extracts of the state's administrative data system, child welfare data on all the clients who are members or who are touched the system from the first maltreatment report all the way through coming into care, or length of time in care through different placements, exits from care and returns to care. And then we post it on our public website. We've been doing that for over a decade or close to 2 decades now as part of the state's outcomes and accountability system. And I'll say a bit more about that in a moment. But I'll start with, when I say the necessary preconditions for transformational change using data, I think that the first step that's necessary for that is a change in mindset. And it's kind of a cheeky a cartoon I'm throwing up here, but I think that in human services, certainly in child welfare, and I would imagine in other human services as well, there is a mindset where folks think that, well, I came into this work to help people. I'm a people person. I'm not a data or a math person. And so you end up running it. If you're trying to use data to improve your system, look for areas where it needs to be improved, you can oftentimes run into these different stages of reactions from the folks that you work with, from complete dismissal all the way up to, on the right, where people think, well, I'm just going to use whatever data I come up with to support the position I already have. And so, with apologies to Dr. Kubler-Ross, we think of adding on a whole new layer of this to where we feel that we want to impress on the workforce from the top down, all levels of the different agencies in the systems, that data are not something that are another component or something that only geeks do, or the data people do, or the data quality or data assurance people do, but it's something that the entire system does, the entire agency does, in order to improve its work with helping the clients that it's charged to help. So a mindset, a different mindset. Then barriers, challenges that we have had to encounter and overcome are, I've listed a couple here. Transparency. Certainly human service systems are used to, if you read the paper, being assailed by sensational stories. And so there has been a tendency, certainly in child welfare, for some time ago, to be a little bit more insular, closed, not sharing our information. And yet that doesn't help to fostering a discussion either across systems, across counties, across jurisdictions within our state, as well as across larger areas across the country, to be able to monitor how child welfare systems or our system is functioning by being closed. And so you have to have the intention to be willing to open up your information so that we can have a conversation, not only within our system, but with other stakeholders. And the important work that Emily was sharing before, being able to share our information so that we can see the overlap between our systems, because in many cases, a lot of the clients that are in the child welfare system or in the mental health system are also in the educational system, and they also then go on to be in other systems as well, in the adult systems, for example. So you have to have the intention. You have to have then the sharing of the information. And Emily, spoke about that important reconciliation work that the Children's Data Network was doing at the state. That's key. Sharing, making those permissions, linking the data on an ongoing basis is clear. And there are certain technical and resource issues that go along with allowing that and doing that on an ongoing basis to support the work. Then finally, masking. Once you present the data, you have to be concerned about client confidentiality. And so whatever mechanism you do to disseminate that information, you have to be always mindful of protecting confidentiality. And so there are masking concerns that you have to be mindful of. Centralized access. This is where my project at Berkeley is, I think, is a really important model, and I'll speak to that in a moment. is that you have to have a place where everybody can come and see what the certain measures are that you're agreeing to track for your system for mental health, for example. If it's only if it's in some database that not everyone can get a hold of, then it makes it very difficult to foster conversations about examining places where we have to, or places of strength and places where needed reform must take place. And then ease of access. It has to be central, but then it also has to be intuitively presented. If you have a great website but nobody goes to it, then that doesn't serve people. If a tree falls in the forest and nobody's there to observe it, it really doesn't make any difference. So you have to have, it has to be easily accessible, it has to be intuitively presented, and then you have to have responsive technical assistance if people have questions, because at a given time, people could go to a place, look at certain measures and not be clear on what those might be saying. And you need to have mechanisms in place to help folks to be able to understand what they're observing, whether that's through quick email responses or a phone call, a telephone number they can call, that sort of thing. And we try to do that at Berkeley. We're extremely responsive on those kinds of things. Then there's developing of the core metrics, right? So you want to have the intentionality, you want to present your data, but then you have to have metrics that you want to pursue as a system. And so developing consensus on those metrics is a very key point that you want to agree on. Like, what are the certain things that we want as a system are interested in tracking? Because it's not what we want to be tracked, but what actually gets measured is what gets done oftentimes. And so agreeing on, having a consensus about what are our system goals is absolutely key. And along with that, as you decide on your system goals, you have to be mindful of coming up with methodologies, measures that you develop that don't take you in a garden path or in an easy direction that looks like you're answering a question, but in fact, it might have inherent biases in it. And so, for example, in child welfare or in any system, if you do a point-in-time count, it's the easiest measure that one can do. How many children or how many clients are receiving specialty mental health services, for example, on a given day? That's a great measure. It's very important to give us a sense of the census count on a given day over time. But if you then expand your questions to system performance, like how long do my clients get specialty mental health services? If you just use that point in time count, you are going to get a very biased answer in terms of the length of time that those clients are getting the services, because, and I will go into it, come to my class on advanced analytics, so we can talk more at length about this, but if you take a point in time count, you end up oversampling on clients who have been in the system for longer periods of time. And so you get a longer estimate of how long your overall client population is receiving services. So you have to avoid the garden path. And finally, you have to be mindful of unintended consequences. As you develop your core metrics, you can say, we want to decrease a certain number of things. That could be one system goal you have, but you have to be mindful that in monitoring that goal, you might have unintended consequences that affect other parts of your system. So for example, if we want to decrease the use of high-level congregate care facilities, the highest level psychiatric congregate care facilities, and that's our goal, that's terrific. But if we can't just monitor the decrease in that, because as we deflect clients off of that highest level of care and we're putting them into lower levels of care, we want to be tracking those clients who are formerly in this high level of care and looking at their needs and because they could have an effect on, for example, placement instability, levels of care in these lower levels of care that we need, and so our availability of those other levels of care, we need to be tracking that as well, placement disruptions, those kinds of things. So unintended consequences and counterbalance measures are another important part of developing our core metrics. And finally, I'll go back to workforce. You have to train your workforce to have the attitude that data are important, but then you also have to build the skills in your workforce from the top down. Most agency managers and deputies are really good at this, but like as you get down to program manager and down to your line staff, they too need to be good consumers of the information. Understand that entering of the data is important so that we can, as a system, track our performance. help use it to help us do a better job. Moving to my next slide, which is around the incentives. Okay, these are examples are all from child welfare, but what I mean to do is to show you some examples of federal and state instances where we've had policy. It's not a silver bullet, but certainly a policy can help mobilize a shared responsibility and shared interest and efforts. And certainly we have observed this in the child welfare field with a federal review and a state review that's built on a federal review of our system. It really motivates people, mandates people to be tracking these things, and it actually gives us the infrastructure motivation to have public reporting and ongoing tracking of our data. And I've put some other examples here. Extended foster care is another one where we're using linked data now to track the transition age youth as they go into different systems, that sort of thing. That's also on our project at Berkeley. And Family First, which is more safety, but the same kind of a motif. And then I'll close with saying promising models. I don't want to toot my own horn, but certainly I think that certainly for child welfare, we've had a lot of success, as I mentioned, with our partnership with the state and with philanthropy in a public reporting portal with measures on an ongoing basis that we report every quarter, refresh a array of system trends and outcomes. And then there are other great projects such as Emily's project, the Children's Data Network with the linkage work, and then some others at the University of Michigan, Kansas, and at Chapin Hall, University of Chicago, where the use of data is an ongoing enterprise to then help the system to do a better job. So I'll close there and turn it over to the next panelist. Thanks very much.
Thank you so much, Dr. Webster. All right, our next panelist is Serene Olin. Dr. Olin is a principal at Health Management Associates. At HMA, she works with states, counties, health plans, providers, and consumers to improve behavioral health care quality in real-world context. Within California, this includes conducting behavioral health needs assessments, as well as implementation of CalAIM initiatives, the CARE Act for the seriously mentally ill population, and the Children and Youth Behavioral Health Initiative. I'll now turn it over to Dr. Olin, and let me get the slides up.
Thank you so much, Melissa. And thank you for sharing the slides. I really appreciate it. Great. So thanks for the opportunity today to share the work that was conducted actually while I was at the National Committee for Quality Assurance a couple of years ago. And this work was actually funded by the California Healthcare Foundation, where we were asked to really essentially conduct a landscape of behavioral health quality measures. And so this white paper with the same title is actually available on both the NCQA as well as the CHCF website. So just wanted to refer people to that in case you wanted to dig into the details. So next slide, please. All right. So today I'm going to highlight a few things from this work. I wanted to share some of the insights that we gained as we conducted this kind of national overview, if you will, about behavioral health quality measures and the challenges associated with the existing accountability measures. I then want to show you a behavioral health quality measurement framework as a potential path for behavioral health entities to embark on the quality journey. And then finally, really walk you through a roadmap for how we might get to joint accountability for whole person care. So next slide, please. I think we can skip over this one. All right, so I think this is just background, just wanted to highlight a few things. I think all of us on this call know that individuals with behavioral health conditions really have, it exacts a very heavy toll on individuals. They have higher morbidity, poorer health outcomes, and much lower life expectancy than the general population. And we know that effective treatments are available, but the care is not evenly distributed. The other thing that we also know is that behavioral health conditions are a huge driver of cost and healthcare spending overall. And this is true across both the commercially insured lives as well as publicly insured lives. And there are studies showing how the outsized impact on costs with very little being spent on behavioral health services. And so, where does this leave us? So I think we're all aware of national efforts that are evolving to pay for value rather than to pay for volume. And I think the reason why Melissa asked me to talk about this, to speak to you all today, is to really try to think about how quality measures could be used to guide value-based payment to support more equitable access as well as outcomes for individuals with behavioral health conditions. So the next slide, please. All right, so why measure behavioral health quality? I think both Emily and Daniel alluded to this in their presentation. We really can't improve what we don't measure. And so quality measurement essentially is the process of using data to evaluate the performance of health plans and providers against recognized standards and performance. And measurement essentially helps create transparency to care. It also could help foster accountability and drive improvements in care. And so typical metrics that we see focus on structures of care, processes, outcomes, also might include things like looking at functionality, quality of life, and safety. So the figure on the right is essentially a preview. I'll walk through this in more detail later, but it essentially shows how in healthcare, including behavioral health, different levels of the health system essentially uses quality performance measures to hold entities accountable for care delivery and outcomes. It could also be used to create incentives to drive practice change and to support a more functional system of care that's more coordinated. So I will illustrate this later on as we go on through the presentation. So next slide, please. All right, so as I mentioned, the impetus for this work, for the California Healthcare Foundation was really to understand how quality measures can help get us to high quality behavioral health care. We really wanted to understand, and so we actually first started to do this by looking at the federal landscape. We really wanted to understand how federal dollars were being used to drive behavioral health care through reporting. And so here's what we found. Not a pretty picture, right? So across the 39 active federal programs that we looked at, we found over 1,400 measures that were required for reporting. So that's a whole lot of reporting. And what we found from our analyses of these measures is that most federal reporting programs actually require a mix of both physical health as well as behavioral health and what we call cross-cutting measures like care coordination. So there was lots of that going on, combination of all these measures in most reporting programs. And this to us signaled a concern about whole person care. And I think that's, where I think all of us in behavioral health are really concerned about. We also found, a heavy reliance on homegrown metrics. And this was particularly true for behavioral health quality measures. Now, we did find 35 standardized behavioral health measures that are being used across different federal reporting programs, but very few were being consistently used across them. And I think the challenge with existing behavioral standardized measures is that they tend to be very narrowly focused on diagnoses like depression and also on very narrow care processes like screening. They also tend to leverage administrative claims data, which I think, as Emily alluded to, it's useful for accountability, but really quite limited if you're trying to use data to improve real-time care delivery. And then finally, we did identify a few innovative programs that the federal government was supporting that focus on integrated behavioral health and physical health services. And in those programs, we found lots of homegrown measures. They were very common. And I think that's because many of the standardized measures that exist right now do not include key aspects of whole person care or behavioral health integration, that are important to folks, to stakeholders delivering this care. So these insights, to us really pointed to a big challenge in shifting to paying for value in behavioral health. So consider the implications of CalAIM and other California efforts for payment reform. Without standard measures, we're really not able to generate reliable or valid information that can help payers figure out what to pay for and or who to direct their populations to. And for the providers, it's also challenging to figure out how to show if they are successful in delivering whole person care. So, so next slide, please, Melissa, I wanted to share. So, I wanted to also, so the other thing that we really wanted to do was we knew that there was a ton of reporting going on across the nation. And we also wanted to learn about the impact of all this reporting. And so we actually did interview a variety of stakeholders across different levels of the behavioral health system in 5 exemplary states. California actually was one of the states where we interviewed a variety of stakeholders who were providing behavioral health care across different levels of the delivery system. And what do we learn? So I don't think it's surprising for folks to hear that California probably has one of the most complex assortment of funding streams for behavioral health care. There's a lot of piecemeal funding to cover important aspects of care, often social needs that influence health outcomes. And each funding stream comes with its own reporting criteria, which are often comprised of fairly rudimentary measures that are not considered particularly useful for improving care delivery. And what we also heard from folks is that the enormous reporting burden drains resources for innovation and for measuring what matters. Additionally, the one thing we did hear across the board was folks felt that behavioral health integration is really key to combating stigma and to improving care access for those with behavioral health conditions. But there was little agreement on who should be held accountable for behavioral health integration and how to measure what successful behavioral health integration would look like. And finally, we heard unanimously that behavioral health data infrastructure and data sharing issues are really significant barriers to using quality measures to drive care improvement. So next slide, please. So, so the other thing that we really pondered on, given what we heard about the limitations of the existing measures out there, we really wanted to try to get a sense of what mattered to different stakeholders. And essentially, this table summarizes what entities at different levels of the delivery system were interested in measuring. So you see the state, managed care entities, as well as providers here. And what we see here is that they agreed on a few things, right? So they agree on how to track both improvement in behavioral health symptoms as well as functioning. So not just symptoms, they wanted to also understand how individuals with behavioral health conditions were functioning. The other piece that they did agree on was a focus around equity, both in terms of outcomes as well as access to behavioral health care. And they were concerned about honoring patient goals. But you also see here that there are key differences, and the key. So just so you're aware, the golden rods are where there were commonalities, and for the rest of them, you see some key differences. And wanted to point out to a couple. One is that states who are responsible for population health are often interested in larger social outcomes like kindergarten readiness, crime rates, employment, etc. Whereas providers were quite adamant that they should not be accountable for things like cost, social outcomes, and integrated care outcomes. Not because they didn't think that these were important, but because they currently do not have the right levers or resources to influence the larger outcomes. And so we see that with rare exceptions, these are not what we are currently measuring in our accountability programs. So next slide, please. Thank you. So our key takeaway was this: so despite the wealth of measures and metrics out there, we still struggle in behavioral health to distinguish high value from low value care. And what measures exist are not particularly valued by providers. And we see this reflected in the vast array of homegrown measures out there. So with this insight, our team really grappled with this question. How can we create a framework for organizing a more responsive and rational delivery system? And I think this is particularly relevant for California at this juncture, which is, it's a state that is undergoing historic policy and payment transformation in behavioral health right now. And the opportunity, I think, is before us. It's really tremendous, and yet it can be quite daunting. So what I wanted to do over the next few slides is to offer a framework and a roadmap that might be helpful. So next slide, please. So what you see here is a framework actually drawn from collaboration with Dr. Mary Applegate, who is a medical director in Ohio State's Medicaid system. And at the time, we were collaborating actually with several centers of excellence across the country as part of a pediatric quality measures program funded by the Agency for Healthcare Research and Quality, as well as the Centers for Medicare and Medicaid Services. Our charge there was to reflect on lessons learned to implement quality measures for children's healthcare, including behavioral health. And those who are interested in this, the publication, the reference is actually listed at the bottom of the slide. But this framework really, I think, was really influential for us at NCQ at a time in thinking about coming up with a framework that could be more helpful. And so this essentially is based on a population health approach to managing care that works from both the top down as well as the bottom up. And the key here is to identify priority populations and engage stakeholder participation at each level to drive reporting on a set of core measures. I think to Daniel's point, really honing in on a set of core measures. So starting from the bottom of this figure, you'll see what we call a microsystem. And so this represents entities who are responsible for providing care and services like clinics, hospitals, community organizations, etc. So there's lots of measurement that's occurring here, but each entity is not responsible for all of them. At the middle level, which is the green bar, the mesosystem, this represents entities that oversee care delivery by providers. So these are large health systems, managed care plans, specialty health plans, accountable care organizations, etc. And these entities are sandwiched. So they need to respond to provider or consumer needs from below, as well as regulatory demands from above. And at the top are entities such as the state and the federal government with the broadest regulatory authority and responsibility for reporting population health metrics. And ultimately, that's where we want to see population outcomes. And so the goal for this framework is really to not replicate measures across levels of the system. The goal here really is intentional coordination, focus on a bundle of parsimonious measures that collectively drive population outcomes. And these measures may be bundled in different ways. They could be bundled across the system, right? So from the state to the managed care levels to the providers, or they could also be bundled horizontally to incent collaboration across different entities who may be working with and who actually oftentimes are working together to support better outcomes for common populations. And so anchored through, this, is really the needs of the population and their experiences and what matters to them. And to date, we have not done a great job, I think, of really capturing those as well to support high quality care. So the next slide. So with this framework, what I wanted to share now is, what do you do with a framework, right? We have a framework, that's great. How do we apply this? And so this slide depicts a roadmap for how we might use this framework and put it into action. I think step one, is to establish key population health goals and priority populations. I think California has done that in a meaningful way. The second step is really to look at measurement tools and transparent reporting structures. And these are key to guide strategies for improving care quality and health outcomes. And to do this, we need to invest in data infrastructure, we need to leverage technology, and we need the support of policies and payment to promote and sustain the alignment of these efforts across the system. So next slide. So over the next few slides, I want to help make this a little bit more concrete with an illustrative example of how quality measures might be used here. So the first step, we talked about identifying population goals and priority population. So we might all agree, for example, that a priority population goal in behavioral health would be to reduce suicidal events and deaths. And so to do that, we really need to move beyond a very narrow focus on behavioral health diagnoses and to look upstream to identify people at risk. And so this might include high-risk populations with behavioral health needs as shown on this slide. Next slide, please. So the second step is really it's about stakeholders coming together to develop bundles of meaningful quality measures at each level of the system. And this slide shows an example of quality measures that includes, outcome process structure measures that might be used to drive the population level goal of reducing suicide. So I wanted to just highlight just one bar, which is the outcome bars, the very top bar in each of the sections, dark blue, the green, and the light blue on this slide. So if we start looking at the outcome bar for states, which is the dark blue section at the top, their responsibility and priorities around population outcomes. So they might track, for example, suicidal events and mortality. To support this outcome, states might develop contracts with managed care entities and focus managed care entities' performance metrics on individuals who show up in the emergency room with behavioral health crises. And that's because we know that such crises are reflective of unmet need for behavioral health services in the community. And in turn, that middle level, the meso level, where the managed care entities live, they might then develop contracts with providers, their network of providers, that prioritize the outcomes associated with the interventions that are being delivered. So in this case, this may include things like timely access to evidence-based prevention and treatment services that have been shown to lower self-harm and suicidal ideation. And then in the last level, the light blue section, the providers, they might focus on metrics related to treatment engagement, metrics related to improvement in symptoms and functional outcomes. And to do so, providers would need to ensure that they have capacity to support or coordinate a full range of services, including crisis response. And the bidirectional arrow on the left that you see in this figure indicates the role of public reporting of key metrics by each entity. And I think Daniel alluded to that. And, this data sharing is so important. The public reporting is so important to help inform efforts by different players who can collectively contribute to the population goals. So you see how, at each level, you can create quality metrics that each entity is uniquely qualified to track. And they can do so quite independently. And I think to Emily's point, we don't have to wait, for claims data to come through. There are things we can be doing today to use data that you collect in real time to inform the care that we're delivering. And so in the next slide, I wanted to finally highlight, the larger system supports that are needed to facilitate the use of quality measures for driving outcomes. And so these include updated policies around behavioral financing to support adequate evidence-based care. And we know California is in the throes of doing that. We also need data infrastructure to support the use of metrics to track outcomes. And then finally, we really need to also, focus on policies that support coordination and information exchange across the system. And finally, I think we all know there's also a strong need for workforce with capacity and training in evidence-based practices and culturally competent care. So the next slide, please. So what So here's what I hope you take away from this presentation today. So if you are an individual in the audience, wherever you are in the care delivery system, here are the things I would like you to be thinking about and how you can contribute to the larger behavioral health transformation efforts in California. So number one, what's your role? How do you contribute to building a full continuum of care for behavioral health treatment and recovery services? We know that a key goal of CalAIM is to transform and strengthen Medi-Cal by reducing complexity across delivery systems. So consider how you might use this framework to reduce all the noise out there and focus on the key structures, processes, and outcomes that are relevant to you and your role in the ecosystem. And then secondly, I really wanted folks to think about the tools as well as the strategies that you might use to help you stay on track. So this might include selecting coordinated quality measures that could be used and that are tailored to your role and responsibility, but are aligned to the larger systems goal. The goal here really is to use data to support transparency, inform strategies to improve the care that you deliver, and to demonstrate your success. And this is going to be increasingly important as we move into the value-based world. Many of us who work with in behavioral health work with highly challenging populations. We've heard repeatedly that increasingly individuals who present with behavioral health conditions have become more acute and more complex. So now more than ever, I think the question is, how do we leverage the historic investments and resources that California has put into the behavioral health delivery system? How will you coordinate and collaborate with key partners across the system, both vertically, so across the state, managed care, and providers, as well as horizontally with your peers? How do you leverage resources, your own and that of others, to create outcomes so that the whole is larger than the sum of its parts? And I know accountability can be a scary word, especially in behavioral health, because we have been so hampered by the lack of good data. But with the right set of tools and strategies, and I think strategic leadership and alignment, we can start to take steps to transform the system. And I think what I wanted to do is to end with a couple of examples. If you don't mind, Melissa, to the next slide. I want to actually, end on a couple of examples in my new role here at HMA. Part of my excitement about joining HMA really was the opportunity to put the framework that I had the privilege of developing while I was operating at a national level at NCQA. And so, I wanted to share actually two concrete examples at a very high level of how we're actually putting this framework, or at least pieces of this framework, to in action. So this is an example here. It's from a state client who actually, even before I came to HMA, was using the behavioral health quality framework to tackle challenges in access to care. And in this case, the state combined two frameworks. They combined the care access domain based on the Urban Institute's Medicaid access to care framework, as well as NCQA's behavioral health quality framework. And so they essentially harness aspects of both frameworks to try to get to metrics that could guide their efforts to improve access to behavioral health care. And this is a work that's in progress. The other example that's not here that I wanted to quickly mention, because it's a California example, is some of the work that we have been doing at the managed care level. And here we've been helping a client develop a tiered provider payment model based on the comprehensiveness of the care continuum. The goal here really is to try to promote a more seamless continuum of care so that it can be a more client-friendly system. And so all providers are being held to benchmarks on 5 types of key performance indicators. We also worked with them to suggest a pathway for how clients could, or how this client could help their provider network get there by starting with where their providers are at, and helping them get to using data to drive care. And so, you know, we can talk, and I'm happy to talk to folks about how we are applying this framework in some of these real life situations. So with that, I'll turn it back to Melissa, and thank you again for the opportunity.
Thank you so much, Dr. Olin. All right. Our next presenter is Marlies Perez, who is or has been a division chief with the California Department of Healthcare Services since May of 2013, and at the state level in behavioral health since 2001. Currently, Ms. Perez leads the Community Services Division, which is charged with policy development, oversight, compliance, and monitoring of approximately $10 billion in behavioral health prevention, harm reduction, treatment, recovery services, housing, and infrastructure projects. Ms. Perez is also California's single state authority on substance use disorders for the Substance Use and Mental Health Services Administration. I'm going to turn it over to you, Marlies.
Thanks, Melissa. Can you hear me all right?
Yep, sounds great.
Perfect. Awesome. Well, gosh, I feel so lucky to be a part of this panel. Just the expertise that I'm following has just been incredible. And I just want to applaud the other panel members and just for the OAC, the mission to be having this really important discussion around data. I've learned a ton already. I hope you folks have as well. I was asked to make this presentation today just to give you kind of some small looks in on some of the data that we have around behavioral health at the Department of Healthcare Services. I'm going to go on record right now, sort of like some of the previous doctors have talked about. I am not a data expert. I'm a policy expert. However, it is so important to have these bridges come together and have key members that really understand data, and also those that are making the policy and make those connections together. So I just want to applaud that you have this important topic today. And so, as you all most likely already know, DHCS oversees several behavioral health funding sources, and we have various data systems. We, of course, as has already been talked about by HMA, we have our managed care plans that oversee some of our mental health data for our mild to moderate population. We, of course, have our Medi-Cal behavioral health system that is overseen by the counties for substance use and for mental health. We also receive federal dollars through the Substance Abuse and Mental Health Services Administration, and that comes down through block grants. So that is for substance use and also mental health. We also receive other grants. We have settlement funds. We have this various grouping of behavioral health funding sources. And I do just want to point out that with that various funding, we have various requirements when it comes to data. Some of those are generated by the federal government, depending on if that funding is coming from them. We have data requirements if it's a settlement agreement or grants, and then sometimes we also receive state general funds that may have data requirements. So they're all a little bit varied, and we have quite a few data sources and data systems at DHCS that track all of these different data elements. And so what I wanted to do is just give you a few brief examples, just to give you a little context. And it's really great following this last speaker, because some of these really highlight her model. And so, as I mentioned, we receive a lot of these federal and state grants. And so depending on what these grants are for, it really depends on then how the data is collected. And so we have, hopefully most of you are aware of the Behavioral Health Continuum Infrastructure Program. And so with this funding, we are building infrastructure for mental health and substance use disorder, so actual facilities. So this type of data is obviously it's linked to the grant, so it's gonna be collected in a different way than per se service data. And so we created a dashboard. I'm gonna show you some examples of that, but basically for these grant funds, what are some of the highlights? And for us here, it's facility capacity, It's where are these facilities located, regional facility type, things like that. So that's a different type of data than service data. Now, of course, as I mentioned, we do receive other grants from the federal government. And so we have data that is linked more towards services. And that's with our SAMHSA, or what we call our substance abuse block grant and our mental health block grant. And that is actual data that the counties provide us on individuals, and that will have demographic data, that type of data that really shows, what kind of services that individual has been receiving. So very different depending on the grant source. And then of course we have a lot of Medi-Cal data, which I'm sure you're familiar with. And this is more around patient outcomes, core measures, service data. And so one of the examples I'm going to walk you briefly through is a behavioral health dashboard. And this is with specialty mental health services, has performance measures. This also has, once again, that demographic data, and then also some measures. And once again, some of these are required by, you'll see here, we have listed AB 470. So some of these may be state requirements. Some of these may be federal requirements. And then some of it is just through our stakeholder engagement as we're designing these data systems, information that is really important to collect for those that are providing the services. And so our example here, I just wanted to briefly show you with BCHIP, back to the grants. So once again, we have different data, and infographics and charts, so obviously data can be displayed in many different ways. This one is just depicting where we have funded with our current BCHIP rounds 1 through 5. And of course, we have so much more data than this. I do have the link above here if you're interested, if you haven't viewed any of this, but this will give you, once again, kind of a feel for like grant type of data that we collect. The next example I have here is around the Medi-Cal services. And so this is what I was talking about with the dashboard. Once again, if you haven't seen these yet, there's a link here that you can go and spend more time with. But this is our mental health plan dashboard. And you'll see here we kind of have a mix of some graphics, really seeing what is, for this one here, it's an access measure. And so what is the measure? So having enough detailed description to help the user understand what they're looking at, because we are not all data experts. I know I'm not. So it's really important as you're thinking about whatever data system you're establishing to think of those of us that are not the data gurus. So anyway, but you'll see here we have listed out for us, because this is Medi-Cal data, also all of the counties information below. So you'll see here, of course, the counties listed, the fiscal years, what type of service, the measure. So we have a lot of this type of data available. And this is really to assist us at the department. So as we are setting policies, or as was mentioned, we've been doing a tremendous amount of work under CalAIM, and we'll continue to do so around streamlining, really looking to see how the program is also, we do a lot of monitoring. How are they doing here in Alameda County with this, measure around time and distance? Because we have a lot of other requirements around network adequacy. So this is just kind of a little window into the type of data that we can use then at the state level for our monitoring and oversight and policy setting, but also that the local level can use for other counties to see how are other counties meeting these measures and learning from each other. So a lot has been discussed already about, we have so much system transformation going on in the behavioral health space in California, which is really, really exciting. And so one of those areas that I think you guys are talking about later on today is around reform. And so I just wanted to pop up really quick here. There is in SB 326 a law around outcomes, accountability, and transparency around behavioral health data. And so just wanted to just highlight some of this. There is a tremendous amount listed in that bill in particular around data and behavioral health data, not just our MHSA that you folks help oversee, but also around all those other data sources and other ones I didn't even mention, but really having some accountability for how are the state and the counties, how are they spending the behavioral health funding? And then what are metrics that are going to be aligned across all of these funding sources that need to be developed, quality metrics. Really looking as those metrics are being developed, looking at behavioral health disparities and making sure that we can see how these metrics and this data, so we can reduce those disparities. So lots and lots of information in that bill. So a lot of, depending on where that bill goes and if it gets passed by the voters in March, be a lot more change coming out, but very positive in the sense that more accountability, more transparency, because as a lot of the previous speakers spoke about, that's really fundamental in really understanding for the ultimate goal is the individuals that we're serving in behavioral health. Are they getting better? Where are the gaps and how can we assist in their long-term recovery? And with that, I'll turn it back to Melissa.
Great, thank you, Marlies, and thank you for coming in representing DHCS today on this topic. We have one more presenter, but they will not be here until 11. So I think I'll turn it over to you, Madam Chair, to start the discussion and questions from commissioners.
Thank you, Melissa. And thank you to our presenters thus far. Emily, I think it's Daniel, Dr. Olin, Ms. Perez. Are there any questions or comments at this time from fellow commissioners?
I have a question. I really appreciate the presentations. Thank you, Melissa, for coordinating and leading this effort. And thank you, Dr. Olin and Ms. Perez for your presentations. I'm curious if Dr. Olin's presentation around aligning across the systems to drive improvement in population goals, your step 2 slide, I know you focused on the managed care section, obviously the state managed care, and then the providers. What's the collaboration with the counties, and how can we get this collaboration increased, or is there any? Can you talk a little bit about that, or if DHCS, Ms. Perez, if you can also, like the collaboration would be great. I think the information that we're hearing is needed and feels like it needs to be inclusive of the counties too, and the wisdom shared and the learnings, because I think we're sounds kind of siloed still to me. So maybe I'm wrong, but would love to hear more about how that collaboration includes counties. Thank you. We can't hear Dr. Olin.
Oh, sorry. It's always that awkward. Who's going to go first? Yeah, it's a great point. And I'd like to expand it a little bit beyond. I'll start with county collaboration, but just even with Dr. Serene, and I really loved your framework because there's such varied levels of data, because it's not even just the counties, but it's not all counties are county operated providers of behavioral health services. So really thinking about providers as well, and really looking in at every level needs a different type of data, but they're all interconnected. And so I think it's extremely important to have collaboration, not only with the counties, but with the providers, because without that, you're going to have a missing link. I also think it's really, really important to consider how do you streamline that, because our providers in counties are extremely busy with actually the provision of services. And so how do you make that data and or that performance measure meaningful to them? And we have some incredible counties that have like really incredible data systems already developed with their own performance measures, with their providers that are pretty incredible. But how do we then draw that up to what we're doing at the state level? And then how do we also mirror that and mesh it with what maybe some of our federal partners are requesting us to do? So I think it's a bit of a dance between all of that. But if you don't have all of those collaborative partners at the table, then I don't think you're going to have successful measures or successful data systems. So I think collaboration is key. So thank you for bringing that up.
And if I could add to what was just said, I think what struck us, because we interviewed 5 states across the nation, and what struck us about California, the county system, is that the counties in California have multiple roles. They manage care and they may also be the providers. And I think clarifying what those roles are and what you're responsible for may be helpful in thinking about what metrics may be most relevant to you, given what hat you're wearing, and making sure that they are in alignment and not conflicting. And so I think, at the provider level, what we found is that folks were just so overwhelmed with the reporting requirements. They essentially said there's no air in the room to even think about why they were measuring what they were measuring, right? And so I think having that deliberate connection, I think, as Marlies mentioned, is so critical. And I think California is particularly tricky because of that dual hat that the county behavioral health agencies wear. And we're talking to folks who are like, well, are we a bank or are we a provider? And sometimes you're both, right? And so what does that mean in terms of the performance metrics that might be relevant to you in those instances?
Thank you. Any other questions or comments? Please, Commissioner Mitchell.
I don't know if this is a question or a comment, and I think I'd really like to hear from, I think it's Mr. Webster, but totally, I absolutely appreciated this presentation. Being I'd say not only a provider, working for a provider, but also a client. Outcomes for me are really, really important. And so when I look at, data, and again, this is not necessarily a question, I just want feedback on it, because the data and the outcomes are so important, but it is so important also to coordinate what we are reporting on. And so that's why I really appreciated Mr. Webster's comments, because we need standardization of quality measures and so that we can get better health outcomes. So how do we do that with the county, with the state, with the federal government? And so I can appreciate FFPSA because it's a great attempt toward that kind of standardization or requirement of standardization. So can Dr. or Mr. Webster kind of give us some feedback or suggestion on how do we get this standardization of reporting and what to report to get the outcomes that we need, or to address those outcomes that we know are going to be poor. They ultimately affect the healthcare system, the education system, the systems with or interactions with law enforcement. How do we coordinate that measurement where everyone within this system of care can actually coordinate those outcomes? I really want to know, is there some global perspective? Is there some suggestions as to how we do that? I believe FFPSA was a great start at that, and I'm sure that there are other things out there, other, bills that are coming through. But can you speak to that? Because what is predictable is preventable.
Yeah, that's a terrific question, and do my best to answer it from our perspective, certainly in child welfare. And then you mentioned FFPSA. It's great. I said it's not a panacea. It's not a silver bullet to have policy, but I do think that that is a good anchor point for mobilizing people's responsibility and their efforts by basically puts people on the hook for a shared enterprise, right? If you just leave it to let everybody kind of measure what they want, then I totally agree with Serene, one of Serene's points about you end up with measure fatigue. You've got everybody measuring a million different things going in all these different directions, and invariably they're going to measure the thing and report it in a way that casts them in the best light. And so by harkening back to my slide about shared goals and shared responsibilities or shared consensus on system goals, I think that anchors everybody towards going in a similar direction. And policy helps us to do that. FFPSA, as you mentioned, is a good one, though it's always double-edged. It has some requirements. You have to have evidence-based practices, for example, which puts a lot of limitations on the kinds of interventions that we can implement. So I would point to, as an example, another thing on my slide, which was Assembly Bill 636, which was the second bullet in my slide, where I mentioned the Federal Child and Family Services Review, which is like FFPSA. It's a federal initiative that says all states have to be measured on certain metrics, and the feds mandated those, and there are 7 system indicators that they look at using data like Emily and Serene and Marlies and I spoke about. But there are other measures as well that they look at. But that system requires all states. There's a process to look at these measures. Here are the ones they specify, and they specify the methodologies for what to look at. And from that flowed the Assembly Bill 636 in California, which, since we're a state-run but county administered system in child welfare, we have 58 different counties, and so we have this state legislation that says, okay, all the counties have to use the same measurement methodology when they're tracking these core system outcomes, and that is a great way to unify everybody, not just the counties and the systems doing the work, but the other stakeholders. And I really needed to interject. We need lived experience. We need the people, our clients with whom we are working, to be part of the conversation as we're developing these measures and how we're looking at things, what we're missing, that kind of thing. That really need to lift up that part of the conversation as well. So I guess the short answer is I think Assembly Bill 636 in California has been, I think, a great success. It's not, the whole enchilada, but it's certainly, and forgive my horrible metaphors, but it has been helpful, I would say. And I think we have seen progress in the measures that system has implemented. But invariably, you're going to come up with measures, and you'll see traction in those measures. But you've got to be continually building in other measures, like I said, counterbalance measures, because as you improve in certain areas, you're going to have other areas that you're going to need to focus on that may not have been part of your initial system that you put together. And you've got to, in the best continuous quality improvement, be monitoring that and building in the capacity to track these new areas of concern. So hopefully that answers at least part of your question.
Thank you. Commissioner Rolette.
Well, let me acknowledge for the commissioners that this was, from my perspective, a very fascinating and multifaceted conversation. Though I acknowledge that I'm a provider of service, and so often felt referenced when the presenters were talking about service provision. as always, wanting the people that the organization that I'm a part of, that we are privileged to serve, to get optimal care and to be a part of not only the genesis of measures that determine whether or not the care that they're receiving is effective, as the last presenter just said, but help us develop measures that make sense to them. Again, I don't need to know everything that my cardiologist knows, but I need to know if my heart is healthy. And that fundamentally is one of the unique challenges I think that we have as a behavioral health community. So I go back to now just two very specific questions, and I think this came from Dr. Olin, and if I'm mispronouncing the name, please forgive me. It's the slide that had few behavioral health measures are consistently used, and you found that 35 standardized measures were used, and I paused and wondered, was those standardized measures used across California or across the states that you queried? So that's one part of the question. And then second, if you looked at specific providers or even managed care organizations that were or counties or government that's providing those services, did that include services that were not evidence-based or community-defined practices? And did you find that the entities that were really advocating and effectively utilizing community-defined practices had measures that were standardized? That was part one of the question, or number one of the questions that I had. The second question is related to infrastructure. And again, my interest is across the states that you queried or across California, where there is a funding mechanism for community-based services, did you find that there were specific set-asides for infrastructure? Because my own, again, subjective experience is that in California, non-government entities or CBOs develop infrastructure themselves to measure whether or not they are effective, because they're going to be asked about effectiveness. But there's no standardization, and there's no even standard funding mechanism associated with infrastructure. We're expected, in my instance, to utilize part of what is described as the indirect administrative dollars to do that. So again, should we prioritize this in addition to that, or should there be a standardized way we go about advising organizations that provide services to set aside dollars for infrastructure? And I assume your answer would be informed by your experience of looking at what other states are doing and what other communities in California are doing. And then my last point is, I only know of one county in California, is 58, and I could be wrong, that set aside dollars for infrastructure for those entities that they contract with. And is that a practice that the OAC should start endorsing or supporting, because we need outcomes to inform the trajectory of service delivery?
All right. Thank you. Thank you for your questions. There were quite a bunch, and I was trying to, I'll try and see if I can capture all of them. And if not, please.
If I could just interrupt, there were quite a bunch because your presentation was amazing. And so it was, it's impossible to digest everything that all of you presented to me. Thinking about this, it was a lot. So that's why there's so many questions.
Sure. No, I'll do my best. I'm not sure I can get to all of them because our sample was limited. But I will tell you, I think your first question related to whether or not, I may have gotten this wrong. I've already forgotten the first question. That's not good. You were asking about, across the nation, states, MCOs, and individual communities, were there standardized measures for community-defined practices? Did I get that right?
You did.
Okay. And so what I will say is that the programs that we looked at were at a federal level. So at a federal level, the push for standardization is essentially par for the course because they are looking at apples to apples comparison. They are really pushing towards being able to set benchmarks that will allow for fair comparisons. And so I think to your point, when you trickle down from the federal to the state and all the translation that goes down to the community level, what we saw was quite a bit of variation. And I think because to your point, community providers on the ground do not have the same level of resources that, say, health plans, managed care entities, or states might have to support the level of standardization that's required. I think as we all know as providers, when you're on the ground, your primary responsibility is service delivery, and oftentimes measurement comes as an afterthought. And so, the lack of standardization happens a lot at that micro level, as I think you saw in that pyramid that I showed. We did see, though, there was a really nice example from California where the local entity worked together with their partners to come up with a set of standardized measures that they all agreed to report on. So if you have an opportunity to go back, so we did this, the talk that I just gave was also part of a national webinar that NCQA put out a couple of years ago. And in there, we did highlight a community in California that was really proactive, who really reached out to their community partners to come up with, I believe it was 6 measures that they all agreed to get behind on to guide how they deliver care for a very targeted population. So it has been done, but they are, again, bright spots and not consistent practice across the country. I think your second question related to funding mechanisms and specific set-asides for infrastructure. I think within the California landscape, given some of the innovation funds that may be available to counties, I wonder if there are opportunities to support providers in developing the much needed infrastructure. Unfortunately for behavioral health, I think we did not get on the bandwagon over a decade ago with the HITECH Act. And so we, in many ways, are playing catch up. And I think, California has, I think I mentioned before, and Marlies also mentioned, there's just historic investments. And how do we use those investments in infrastructure funding mechanisms to begin to build out that infrastructure? I've seen people do it on Excel spreadsheets. They don't have to be fancy. I think we all have to start someplace. And I think, like I mentioned before, one of our clients actually is essentially starting from scratch. They're trying to meet providers where they are, helping them build, paying for reporting, and then eventually build a path to paying for performance. But I think we all have to start someplace, and trying to lay that foundational step is going to be really critical. And I think you had mentioned that there's only one of 58 counties that set aside infrastructure fund. I'm not sure I could comment on that, but perhaps someone else would like to jump in. So I hope I got to most of your questions.
You did, and thank you.
I understand that. Commissioner Gordon, please.
Yes, thank you. I also enjoyed your presentation, Dr. Olin. What I was wondering is that we've focused so much on treatment in our current system rather than prevention. And one of the things, I serve on the First Five Commission, and I've been watching this for years, and serving as a school superintendent. When a lot of young people reach us at age 4, 5, and 6 years old, they have deep-rooted deficiencies which don't stem from the child alone, but in many cases they stem from the fact that the young people haven't had the benefit of the medical system working with them from birth on. And that seems to have been a big indicator of trouble down the line when they get to school and beyond. So just looking at some measures like well baby examinations, the requisite well baby examinations at the prescribed age levels. We're looking at 70% only get those. So 30% of young people don't even get the well baby checkups. Now that speaks not just to deficiencies in the children, which are undetected, it speaks to the fact that no one is bringing them, even though they have access to medical care, no one is bringing them forward for those services. So what I'm wondering is, are there these leading indicators of things that portend problems down the road, which are pretty simple to actually access? Your MCOs can tell you what proportion of young people meet the well baby care checkup standards, and really trying to focus on those early age levels where school-based screening is fine, but it's awfully late for a lot of our young people. So I wondered if you comment on, have you seen anything like that on a major scale, either in California or elsewhere?
So in response to your questions, I believe, I haven't looked at the core set measures in a while, it is actually one of the core set measures across the nation to track well child visits. So to your point, I believe that there is data both nationally as well as the state level in terms of the percentages of children who actually receive well child visits at any point, at any given time point. So the data is there. I think I think to your point is, how do we use that data to inform strategies or apply incentives to encourage, I think, caregivers to bring, to your point, babies don't bring themselves to treatment. It's the caregiver who does. And so how do we incentivize and support that? And I think, I was following California's dyadic services benefits. I mean, that is such huge progress in terms of having those services available. But I think to your point, how do we get, A, raise awareness of those services, B, support? Oftentimes, the caregivers who are challenged in accessing those services have a multitude of challenges that they're dealing with. And so how do we support these caregivers so that they can meaningfully access these services that are available? And so, we could probably think of other ways. And so to me, the leading indicators, as you call them, are a way to identify where some of the attention needs to be focused on, and then diving in deeper to understand the kinds of barriers that we may need to address to help get them to the care that they need.
Thank you.
So I understand that we have our next speaker. There was one more speaker on this panel, so we're going to go ahead and invite that speaker forward. I just wanted to make, I think it's more of a comment and maybe a question. And as we were working on the prevention early intervention report, I remember one of the first things that we tried to identify was going through all the PEI programming across our counties, across the 58 counties. And so we had one of our staff members start to look at all the PEI reporting that was done. And so you would think, we're going to start counting apples, oranges, bananas. And then we started to see, wow, there's peaches, and here's a passion fruit and a guava. We couldn't, because the definitions varied based on what county you were in. Everybody had their own definition of what PEI looks like. So I guess this probably to Ms. Perez, as we start to work forward with BHSA, what that looks like, I appreciate everything that I heard from Emily, Dr. Webster, Dr. Olin. I didn't see anywhere where we talked about definitions. So if we don't define it the same way, measuring seems like so much higher level, next level. And so it's just something I thought about as we were going there. So how do we make sure that we're all on the same page so we can start to talk about intentionality in the data? I think we just need to be really intentional in how we're defining that we're doing, defining the same thing. So I just wanted to say that it was very concerning that what prevention looks like in San Diego County looks vastly different in Yolo County or Marin County. So how can we, you're going to get out what you put in. And so how can our measurements ever be truly accurate if we're not on the same page? And in education, that would never fly. I think of the competencies in SEL, self-awareness, self-management, responsible decision-making, relationship skills, and social awareness. There is no wiggle room. We will count that. We know it. It's exact. We have to be that exact when we're talking about the mental health of Californians, and we have to get this right. So so maybe it's not a question, I'm commenting. So thank you. Please, Melissa, let's invite our next speaker so we can continue to move forward. Thank you.
Great, thank you, Madam Chair. We're going to hear from two presenters from McKinsey. They're going to offer some closing remarks on our data agenda item today, and then we'll move to public comment. I want to introduce Samir Chowdhary, who specializes in healthcare and business technology. He has particular expertise in working with health insurance organizations to achieve operational excellence and optimize cost baselines. He'll be joined by Kana Enomoto, who's the Director of Brain Health for the McKinsey Health Institute, a nationally recognized expert in mental health, substance use, social determinants, and trauma. Kana advises the full gamut of healthcare stakeholders on reducing the burden of mental illnesses and substance use disorders in the US and beyond. Welcome, Samir and Kana. I'm going to turn it over to you.
Thank you, Melissa. Appreciate the opportunity to share our thoughts, experiences within this forum. Gabby, if you can pull up the slides.
Let me make sure. Can we give Gabby co-host privileges? Great, thank you.
There you go. Can everyone see the slides here? Okay, fantastic. So before we get started, I just wanted to say that there are few things as personal, as intimate, or essentially human as our mental health. And yet, as our use of data to drive transformations evolves in our societies and in our lives, we find ourselves asking the question, what does this mean for the future of mental health? We think it's important to consider the basic tenets of transformation and transformational change and the vital role that data plays in that. So what I wanted to start by going through was just the elements that are helpful in bringing about sustainable transformational change. And what we found is that these elements can usually be bucketed into four broad categories, as you see on the page. So I'll start with the top left. It's about, as you are embarking on a journey to change or to embed innovation in the way that people think about their projects, their initiatives, it's important to make sure that they see that in the language that's being used around them. And they see that being role modeled by the leaders that they work with. So it's important that that the leaders within these entities, organizations, actually make that a part of how they communicate, how they interact with their teams, so that the employees, the staff, the overall organization sees that it is an urgent topic, it's an important topic for the broader organization. The second one is just making sure that as you embark upon that change, that there is enough communication and enough understanding about what the common goal is. Where are we trying to move towards? And then what is the individual's role in it? There needs to be forums where, if there's questions, if there's not enough clarity, that folks are able to ask questions about specifically their individual roles. And that understanding will then create the conviction to make sure that change sticks. Third is, as you start thinking about moving in a particular direction, as you're talking about data, for example, it's important to make sure that there is training, there is upskilling, there is capabilities that are provided to the organization, to the employees, to the individuals who are going to be playing a key role in that transformation. And then lastly, it's about surrounding all of this with formal mechanisms to make sure that there is a governance structure that helps everyone stay in touch with what the progress has been, where the issues are, and what challenges need to be resolved in a collaborative manner. So making sure that there are all these processes, all these systems that become a part of the fabric of how the organization is overall moving towards that change. Now, if you then start thinking about what the implications are for each of these elements that are required for transformational change on the underlying data and infrastructure, we can look through each of the elements, and each element actually has a data thread or theme going through it. So as we look at role modeling by the key players, key stakeholders, it is important, if the leaders have to be effective role models for transformations and database decision making, along with integrating data analytics and technology into how things are done, they also need to make sure that they are actually highlighting the importance of data. If leaders demonstrate an integrated approach, more likely that others in their sphere of influence will start doing the same. If we look at understanding and conviction part of the quadrant, ensuring that there's clear understanding of everyone's roles and overall objective, encapsulating those in a few key metrics, KPIs, will cement not just individual teams' objectives, but also how it ties to overall goals for the community and the organization. As we start thinking about developing capabilities and skill, as I already mentioned, embracing data analytics, latest technology will be essential for the transformation. And therefore, this needs to be embedded into the overall talent strategy as well. So it's not just about training the employees that you have right now or training the broader teams. It's also about making that a part of your talent strategy going forward. And then lastly, the reinforcing with formal mechanism, this takes the shape of introducing dashboards, introducing reporting, having the right data and technology infrastructure to be able to allow the effort to keep track of progress as we go along. As we introduce OKRs or key metrics or KPIs, that everyone is informed about what is on track and what is sort of falling behind, so that corrective measures can be taken. If we switch to this next page, what we also wanted to do was just share a few examples of how data has been used to drive change across the globe. So one example that I can share is in Singapore, the Ministry of Health incentivized the population to register the steps that they walked each day, along with a few other lifestyle metrics to encourage people to be more active. That team now that's working on this initiative is now combining this lifestyle data with medical data for citizens to identify thresholds for level of activity that can have meaningful impact on health outcomes, on reducing health risk, on perhaps bending the health cost curve. And for this initiative, data is the backbone on which all of this is getting built. And they are now starting to venture into analysis of how do we figure out what the reduction in incidence of chronic disease could be as it relates to the amount of activity that an individual goes through during a day or during a month. So they're trying to start to figure that out, right? So this is the kinds of things that data can enable. I will pass it on to my colleague Kana to take us through a couple of other examples of use of data in public sector.
Great, thank you, Samir. And it's wonderful to be with this august group. And I am just so appreciative of your focus on data-driven transformation. As I know, the Commission has been tracking closely, there are a number of national priorities, including the transition to 988, where data has played a really critical role in ensuring that our country was prepared to manage the changes that came upon us in a relatively short amount of time. So the second example here is Vibrant and 988 and the work that they and SAMHSA did to ensure that our country was prepared for this watershed event. First, there was considerable efforts looking at modeling and projecting the estimated impact of launching 988, trying to base off of current data or past data now, what we might anticipate in terms of increases in call volumes, chat, text volumes. At the time, there were several different scenarios and landed on, where there were in FY21, 3.6 million contacts. I think the estimate was that there might be a 30 to 50% increase in volume as of July 2022. And so Vibrant wanted to understand from the network, how can we ensure that we have the capacity that's necessary so that we don't miss calls, that nobody who is in need doesn't get their call answered, and that we experience the tragedy of making a resource available that doesn't have the capacity to serve people at their most vulnerable moments. And when Vibrant surveyed the contact centers nationally, they found that only 1 out of 8 contact centers said that they would be able to handle the 30% increase in volume, which was at the low end of what was anticipated with their current staffing. And more than 2/3 of contact centers said that they could handle the 30% increase if they could increase their staffing. So, armed with these data, as well as other data points about capacity and specific capabilities, SAMHSA was able to galvanize over $1 billion investment from Congress, from the administration, and to disseminate that to states and contact centers to prepare for the transition. And they continue to this day. Vibrant makes the contact center data available, or the state data available, in terms of meeting the goal that SAMHSA set for having 90% of contacts answered in state. And so we are seeing very transparently the progress toward that. And so by July 2022, there was, in fact, a 46% increase in volume year on year between 2022 and 2023. So not only was the Lifeline able to successfully manage that substantial increase in volume, but they were able to reduce the average speed to answer across all modalities by 74%. So what was taking 2.5+ minutes to get a call answered went all the way down to taking 40 seconds to get a call answered, which is just tremendous evidence of the impact of data and how that can drive transformation in such a meaningful and immediate way, which is we're also glad to see. Another example is in the state of Rhode Island, where we know that California is also incredibly committed to the issues of health equity. Rhode Island was able to approach this issue from a very tech-enabled, community-centered way that was looking at data at the zip code level and converting it into insights that allowed community leaders to target specific local concerns, and also for policy leaders to make the case for increased investment. So maybe next page. If we dive a little bit deeper in their approach, you can see, so Rhode Island Department of Health convened partners from diverse sectors, including businesses, governments, academia, community members, obviously health equity zones. And they spent a couple of years actually with the Community Health Assessment Group and the Department of Health to develop a consensus set of statewide health equity measures, and then implemented that in implemented that in this tech-enabled, community-driven way, so that there was that buy-in at the local level, and the state encouraged members of the public to use these measures to assess the progress toward health equity in Rhode Island. And so you can see that they were able to raise $10.4 million to invest in their health equity zone initiative. They saw a more than 150% increase in community engagement, and also meaningful decreases in health outcomes for communities that were traditionally underserved or marginalized. So you see lead poisoning was reduced in one community by 44%, which has long-term social, health, and financial implications. So they learned that tracking these metrics at this granular geographic level allowed for targeting of specific local concerns, having clear consensus health equity measures. I think it was discussed earlier, if we all have a different definition of PEI, then how do we know if we're making progress? You have to have an apples to apples comparison. And then providing evidence of specific disparities and then quantifying that magnitude was able to galvanize policy and funder action so that they could demonstrate an ROI and give people the why for this investment of their time, energy, and funding. So, I know that California and the commission itself has a commitment to these 7 levers of transformational change, which does incorporate putting data systems in place to create transparency and accountability and to have clear outcomes that are driving collective action. You've done a lot of thinking about this topic, and we hope that examples like Rhode Island, like Vibrant, like Singapore are able to give you some just thought starters or food for thought in terms of what more the state can do. And in the meantime, we are very inspired by your commitment to improving the state's mental health through data-based transformation. Thank you. Thanks, Melissa.
Thank you so much. And that concludes our panel presentation. And I just want to extend so much appreciation and gratitude to all of our panelists for their wonderful presentations. So thank you so much. And with that, I'll turn it back over to Chair Madrigal-Weiss.
Thank you, Melissa. Thank you, Kenna. Are there any other questions or comments from commissioners at this time?
I just have one quick question.
Please, Commissioner.
Again, that presentation was just beyond excellent, very informative, because data does inform policy. So it's so important. So thank staff for putting all of that effort into bringing that to us. So where next? Next steps? That's my question.
Melissa, next steps.
I'm so glad you asked. I think that one of the areas that we as staff would like to focus on with the guidance and direction of the commission is to really engage in our own community outreach and engagement to identify what metrics and quality measures different community partners would like to see us focus on as a system. So I think for us, that's one of our next steps, and trying to kind of bring some of these frameworks and ideas and mindsets out to the community to really get our feedback from our community partners.
Thank you, Melissa. Any other questions or comments? Okay, we see none at this time. Melissa, we are very thankful for this excellent panel you put together. I think we've been talking about this for a long time, so you've given us a lot of information and material to continue to review. Again, I want to thank Emily, Dr. Webster, Dr. Olin, Ms. Perez, and Kana. I hope I'm saying that, Kana. Oh, we have one more comment, 2 more. So please, Commissioners Rolette and Commissioner Gordon.
I would hope that the commission would consider making a bold statement about data and not only the implications to inform policy, but service delivery. and then identifying what is the ideal way to incorporate all the uniqueness that is California, meaning being mindful of evidence-based or typically federally funded practices and practices that are measured or standardized by the federal government, but also what is unique to California in some ways, community-defined practices that are often inculcated in a number of different organizations, managed care entities, and appreciated by the people that receive the service. And then lastly, making sure that this bold statement about what data should look like and how to operationalize a plan that really does result in the commission endorsing something that robustly says, this is how we're going to collect data, California, or this is how we think you should collect data, California, includes the perspective of every person that is a recipient of service that wants to be involved in the developments of such a plan or policy statement.
Thank you, Commissioner Rolette. I think we should absolutely do that, and we'll work with Melissa and also with our commissioners working on the data and research team to start to develop that. So thank you. Commissioner Gordon.
Yes, I couldn't agree more with Commissioner Rolette, but on top of that, I would really urge us to, both in our conversations with stakeholders, but also in the plans we come up with, to really try to focus on, number one, prevention, but number two, prevention from the perspective of working with families, not just individuals in the families, either the adults or the young people, because I think we can, especially with the expansion of pre-K and universal pre-K, we have an enormous opportunity to dive into that space with data which can be relatively uncomplicated, and work with our managed care partners, our managed care plans, and capitalize on CalAIM and the great relationships we're developing with behavioral health at the state level, DHCS in general, the governor's initiatives, because I think we have a window right now where we can really push this, and it doesn't have to be a total revamp of the data system, but picking and choosing, because we're in my county, we're trying to work now with family navigators who are available to the families from 0 through school age and so on. So I think it's just a wonderful opportunity, and I think there's much to be gained.
Yes, now's the time. Thank you, Commissioner Gordon. We will absolutely get on that. And so we have written that down, and staff is going to make sure we take care of it. So thank you both. Other comments, questions?
My one last comment, Dr. Gordon just said, he articulates so well. He said really what I was thinking in terms of the piece to get the families involved, because, the data shows, or I would love to see a study on, how many families are really involved and what that trajectory looks like when we don't include families in the behavioral health system, and particularly, when our kids come through child welfare, because there's this big gap and there's this disconnect, because often families are considered the problem when these kids come into care, but we know that children do better when they are at least involved with natural supports. And so I don't know how we incorporate that into this whole data discussion, but the family is central to the health outcomes. Even the worst family, that kid is going to go back to that family as soon as he is out of care, he or she. Right. So we must connect that piece to this data conversation.
Yes. Thank you. And we have Melissa, who is documenting all this, and we'll loop it back in. So thank you for that, Commissioners Rolette, Gordon, and Mitchell. With that, we want to again thank the panel. Melissa, you hear us?
I do, loud and clear.
All right, we appreciate that. We are now now is time for members of the public may request to make public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Mariani, please open the line for public comment on agenda item 5. And we will start with any comments in the room if there are any.
Okay, we don't have any comments in the room, but we have 2 comments online. The first one we have is from Mark. Your line is open.
Hi, this is Mark Kremetz. I don't hear.
Go ahead, Mark.
1 second. Mark, are you able to speak?
Yeah, I can pipe in now. Will peer support be available and be part of this data process, and also be available once the changes in the MHSA and the to become the Behavioral Health Services Authority or whatever be there? Would it be when they get the supports into the housing, and when they get the housing, 30% to go to the housing, will certified peer specialists be available, be a part of this at all? And if not, why not? And I don't know how to get the answer on that one.
Mark, we will have more conversations about that later on in the afternoon. So if you want to ask that question then, not ask that question, if you might make comment then, and you can always email the staff for specific questions. So we'll go ahead and move on to the next public comment, please.
All right, thank you. Next we have, I believe, Steve Leone. Your line is open.
Hi, can you hear me now?
Yes, we can hear you.
Good, thank you. I just wanted to comment that I've been attending some of these hearings, and hold on for a minute because this is about an agenda item later today, but it's relevant to this one because I was 2 days ago, I spent the whole day listening in on the Health Committee, the joint with Housing, on the governor's proposal, and a lot of interest, as there has often been, in data and understanding things better. And I think there's some interest in maybe going forward later on, maybe because this could be further additional legislation. But what I wanted to relate was that in their panels yesterday, they were talking about the need for writing data down and doing reporting. And one of their panelists was a supervisor from the county of Santa Cruz. And he pointed out that there was a tension between, in his opinion, if you're doing reporting, you're not doing services. And Councilman Arambola said that at this point, there is, as he put it, a Hobson's choice between one or the other. And it was quite clear that the supervisor from Santa Cruz was saying, we can't really afford to do the reporting. Now, every time I've been involved with something, they always say, we're going to do a new data system, but we can't collect anything other than what we're already collecting. And I think what you need to do, and I've talked to Toby about this in the past, but we need to have a much better data system. The counties and the state in particular, some of the departments using 40-year-old programming language. There's ways of setting up data warehouses, web tools, etc., that allow you to be much more efficient in reporting the data. Do it less, like many only once instead of many times, so that you can collect as productivity gains is what I'm trying to say. In the 20th century factory jobs, people were so well off under those jobs because they weren't just handling shovels; they were handling gigantic machinery. And we need to stop having just shovelfuls of data and processing it repeatedly and have it just go in once and we have it all set up. I can't explain it very well in this short time available to me, but I think we should be looking at that, and so that we can actually collect far more data with far less effort. That would be revolutionary and get us to the goals we're trying to do. Thank you.
Thank you, Steve.
We have our last public comment from Steve McNally. Your line is open.
Very much. I appreciate that. I raised my hand late. I couldn't figure it out. I love this presentation, and for a variety of ways. One, it's what we all need, but we can't seem to get there for some reason. And in California, and people do make a difference. And so a couple of questions I had, and it's similar to, I know we don't get an answer today, but the presentation about the integration of social services and welfare and relative to mental health, how do you replicate that in another county? I mean, if people were willing to do it, is that something that we could just assign a dollar number to it and do it? Judge Leifman in Miami did the study in 2008 and 2009 about how much it cost of the system by a small number of people, and yet we still struggle to get similar data here. I'm aware of LA being one of the counties that has great data, and for MHSA with Debbie and Escomberg, and I've always asked, how do we replicate that in our county? And it just goes nowhere. So maybe it's not replicable, maybe it can't be replicated, but I keep thinking everyone's working with the same kind of legacy systems or maybe similarities. What I like about this presentation is the framework for organizational development. When you have matrix management, it's very difficult for people to break out of silos because nobody's over anybody unless they're willing to accept a leadership role and a participation role, depending on what it is. And to Commissioner Gordon's comment, many times we've looked at how are we leveraging first 5 to MHSA or looking at a 0 to 100 age, all the services people do interact with, and who should be the lead case manager, and maybe we pay extra. That's what we would do in the business world in advertising. If I had 15 ad agencies buying the same thing, I'd assign one of them and give them some extra money to manage the whole process. So families, we see it as one system giving us services. And I do think there is an issue of awareness and understanding of even what we do.
Steve, you might have muted yourself. Did we lose him?
1 second.
Oh, I'm sorry. Was I muted the whole time?
No,
Not the whole time.
Not the whole time.
Probably the last 20 seconds.
All right. Thank you for letting me know that. Anyway, I just love it. But I think a mind shift is definitely needed in the state. You all are the most influential of our subgroups, to the planning council, to the local boards. And if we don't establish two-way communication, it's hard to believe we can provide all these services and we don't know if people are even satisfied with them. So a lot of baby steps. It's not that hard as some people try to make it. At least that's what I think. So thank you very much.
Thank you, Steve. We are a little ahead of schedule, so we're going to go ahead and move forward with agenda item 7. The commission has received $200,000 in the 2023-24 budget to explore avenues for universal mental health screening for children and youth. Staff will provide an overview of a proposed plan to accomplish the goals of this funding. Today, we will hear from Kaylee Patterson, who is a research supervisor for the commission. And we are doing this so we can just have ample time to have discussion for the legislation discussion in the afternoon. So just want to make sure we have enough time for everything. It's fine. So Kaylee, please go ahead.
Thank you, Madam Chair, and good morning, everyone. Thank you for the opportunity to present today. Cody, if you could please advance the first slide of the presentation. Cody, can you please put up the first slide? Thank you. So as Chair Madrigal-Wise said, I'll be talking about the Commission's plan for an initiative to explore opportunities for universal mental health screening for children and youth in California. Next slide, please. So I'm going to move quickly through this. I think, this is information that we have been sort of, for lack of a better word, sort of bombarded with for the last several years. Just not that it's not important, but it begins to feel a bit daunting just in terms of really the reality of the crisis that we're seeing in youth mental health. We know that the majority of mental health challenges occur before a person enters adulthood, with as many as 75% beginning before the age of 24. We also know that at least 30% of youth in California are currently living with a mental health challenge. This data actually is a couple years old, so it's likely that those numbers are even higher. And yet, as many as 60% of those youth with an identified mental health challenge are reporting that they're not receiving any type of service or support. And I don't have it reflected up on the screen, but I have to point out that we know that within these numbers there are stark disparities impacting some of our most vulnerable, disadvantaged, and marginalized communities. The consequences of failing to support mental health needs of youth are dire, leading to a lifetime risk of increased mental and physical health challenges, reducing life expectancy by as many as 20 years. In California alone, in 2020, an estimated 527 young people died by suicide, and half were younger than 20. So just to really paint the picture of what we're facing here. Cody, next slide, please. So the good news is that we know that if we implement strategies that identify mental health needs early, and if we can support those needs early and effectively, that we can drastically prevent these negative outcomes from occurring and reduce suffering. But in the nation, the average delay of receiving services is 11 years, which to me, and I hope you agree, is just unacceptable. And really, screening, like in other areas of public health, is really seen as a key strategy to help close this gap in services for mental health. In fact, it's even required by in healthcare that any child receiving services under federally subsidized healthcare or Medi-Cal in California is required to be screened. Yet we know that in California, millions of eligible children are actually not receiving that screening. This would not be tolerated for things like vision and hearing and other developmental milestones for youth. And many experts are in both health and education and mental health agree that there should be no exception when it comes to mental health screening. Cody, next slide, please. So as we all are also very aware, particularly through the work that the Commission has led and around mental health in schools, school is just a critical strategic setting for mental health support, promotion, prevention, and really screening is seen as a key component of this comprehensive school-based mental health approach. Universal screening in particular, where it, rather than screening only youth that are showing signs of distress, universal screening includes screening all children. And so the idea is that if you're casting a wider net, you'll identify more needs, prevent more negative consequences. Also, there's just a tremendous need for data, as we spent the last 2 hours discussing just the critical importance. Screening allows the sort of establishment of a baseline of data that allows effective monitoring over time. So really for, driving this data-driven approach to high-quality mental health services, screening just is really part of that, that robust data-driven approach. It's also incredibly cost-effective, and it can prevent the need for intensive interventions that are very expensive and often less effective than early intervention. So despite these benefits, screening, particularly universal screening in schools, is highly underutilized. An estimated 15% of U.S. schools currently implement some type of routine mental health screening. The data is really inconsistent because there's actually a lack of consensus around what mental health screening even means. The data is just very limited. But there are a lot of concerns and it's not really, the question isn't whether or not screening is effective or needed. It's really has more to do with capacity concerns with our already overburdened education system. There's a need for training and infrastructure to support screening in schools. There's also still just a lot of stigma around mental health. As we know, there are concerns around issues like parental consent and even down to what tools should be used for screening and how they can apply to diverse communities. Next slide, please. So under the current administration, California has made just monumental investments in doing a better job in supporting youth mental health with initiatives like California's Youth Behavioral Health Initiative, MHSSA, ACEs Aware, and others that really to build out this full continuum of care that emphasizes prevention, early intervention, to reduce these unwanted outcomes that we've been discussing. And California also recognizes the role of mental health screening, particularly in schools, to support this continuum of care. So in response to this recognition, the legislature has asked the Commission to do one of the things that it does best, which is to draw upon its levers of research and community engagement to really bring to the surface what these opportunities are for screening, what the barriers are, and again, with a particular focus on screening in schools. So the legislature is specifically, it wants to understand just what does the research say, what are best practices. It wants to know what is happening in California because, as I said, the data is really inconsistent, it's really difficult to find. But there are some really good things happening in model programs, and so looking across at what those models are, including some of perhaps what is happening with our MHSA grantees, for example. But there have been just a number of other pilots, so that will be a big part of this initiative as well. And within this analysis, really describing the costs these tensions that I mentioned, and barriers to implementing universal screening, and identifying what it takes to make progress. So from this work, the legislature has asked for recommendations to inform future budget and policy considerations around advancing this critical strategy of mental health screening for youth. Next slide, please. So as you'll see in the next presentation, the commission's budget reflects $200,000 to support the legislature's request, and staff have drafted a plan that identifies key activities for the use of these funds and to support the legislature's goals to understand opportunities for universal mental health screening for children and youth. This process will include a robust research and review process to really set a foundational knowledge of models, tools, best practices as recognized in academia, clinical practice, policy, and government. We will do a really comprehensive outreach and engagement process to engage with a diverse array of experts, community members, educators, providers, and other key partners to understand these opportunities. And finally, the initiative will end with the development of a final report, which will be presented to the commission that will include the recommendations for the legislature. And the ask is that this is all completed by March of 2024 in terms of a timeline. So now I'm gonna, next slide, please. I'll open it up for questions, comments. Thank you.
Could you say more about how you propose to do the outreach?
Like what types of activities?
Well, yeah. So let me frame the question a little bit differently. In addition to all of the things you mentioned that could be barriers to having students be forthcoming, there's also the issue of if school people see you come to screen, they will expect follow-up based on what you found. And if we're not in a position to provide follow-up, the screening will not only be not effective, it will be discredited. And we've seen that in our community. So in terms of the outreach, well, I would offer up some of the things we're doing here in Sacramento, because we decided that we should try to place a mental health clinician in each of our schools, funded by the Medi-Cal system and sustainably funded, so the school districts didn't have to worry about their paying for it. And the mental health clinician works in the schools, and we've got about almost 40 schools now with a mental health clinician on site. And what we're finding is that young people are coming to that person to report concerns about their mental health, but they're also coming to report that stigma is very much in play, particularly in a lot of our neediest schools. So I just want to offer up in the course of your field work, please feel free to come to us, because I think it would help you a lot, not just to talk to the clinicians, but the clinician is there placed in the school in order to bring the health system closer to the education system, so that follow-up is not at issue. If a student comes forward, the follow-up is built into the system.
I think you bring up just a really important point, and thank you so much for your question. In some ways, I think you answered it yourself. And thank you for offering that up. Certainly, we would love to engage and see what's happening here. So, you know, I think when we're thinking of engagement, there's some sort of key stakeholders that really need to be considered. So you mentioned this sort of tension around it's not just screening, but it's building out that continuum of care that ensures that screening results in services and support, and that we have the infrastructure and provider staffing to meet that need. Because once we start looking, and that's a fear that the more the wider net we cast, we're going to identify more needs, but if we can't support them, then what's the point? Now, you know, just as a side note, that wouldn't be an acceptable excuse in other areas of healthcare, right? So it is both. But understanding what would it take in terms of, you know, incentives, capacity, billing mechanisms, all of these things. So really understanding that from providers' perspective, from the school's perspective, from and then also, you know, parents and students themselves, and what barriers are they're facing, and that's going to look very different depending on the community we're talking about. I know in particular, screening is underutilized more in some certain communities that kind of are still grappling with, you know, the school's role in mental health in general. I don't think that that's a consistent understanding from a community standpoint necessarily, that they're not invested. So it's kind of understanding that, but really leaning into it and saying, well, what would it take to convince you or to be invested? So yeah, really kind of hitting all those key players. But I would love to talk more with you too about you know, some opportunities to support that engagement. So thank you.
Yeah, and I guess the other snare in this is also that part of our approach in putting in the clinician is to build more of a one system approach to building relationships with young people and making sure you're cued into their needs and their issues, whether they're educational issues. So there's a whole body of work on social emotional learning in schools, which ties right into this, but again, has to be linked to the health system. Correct. So that everybody's profiting from the relationships that are built largely in the schools, because the referral system is in itself a big barrier. Because if you take a 13-year-old child and say, we're going to send you downtown for some service, probably not, because the relationships haven't been built. So anyway.
Yeah. Really good point.
Anyway, I think this is a marvelous opportunity for us as the commission to help work with the state on how to pull this off. So thank you.
Thank you. Yeah, I agree.
And we'll talk after.
Yes, certainly.
Commissioner Robinson, please.
Just a quick thought about how you plan to outreach to kids, the growing number of kids who are homeschooled. Are they going to be, how will you include those in this? Because it's a growing number, and we certainly want to make sure that we're tapping into that population.
That is a very good point. And to be frank, I hadn't really thought much about the homeschool population. But that is something that definitely needs to be considered. And thank you so much for bringing that up. And would love to talk to you more about that too. Thank you.
Please, Commissioner Roulette.
Last month, and this was more of an assertion versus a question. Last month, we had Dr. Galaxiola, who did a marvelous presentation around engagement and engagement strategies that specifically result in the kind of outcome that Dave talked about. And thank you so much, Commissioner Robinson, for talking about kids who are homeschooled or utilizing an educational method that is different than the traditional public school system. And all those strategies that he talked about would be effective in engaging in families, children, and even ensuring that the school systems or the educators don't feel alienated in the process. I'd strongly endorse ensuring that you use some of those methods in order to meet your March 2024 deadline. Highly effective. And then what is additionally important to all of us, I'm sure, is that those methods take into consideration the social determinants that often, as Dave alluded to, prohibit participation or result in people saying, there's too much stigma associated with behavioral health, not going to go there, and I certainly am not going to go downtown to get services because that clearly identifies me as being a participant in behavioral health. And by the way, that takes gas money and time, and I'm not going to do it. And so that is Dave's point. What he is implementing, it helps people overcome those determinants, those barriers. And then again, for the homeschool population, it is just a whole different set of variables that you want to take in consideration as you begin to effectively engage them. And so the importance of making sure that as you draft this, you include people who are going through or have gone through a homeschool experience and their educators as part of taking a look at what you've developed.
I couldn't have said it better myself, and thank you so much. And I think, yes, and this is why the commission has been asked to do this work, because we do lead the state, much of the state, in our community engagement. Not that we don't have room to grow and improve, but it's certainly something we're invested in. And I think you'd be happy to know that the plan is to engage with, I'm always going to say his name wrong, so I get nervous, but Dr. Gaxiola.
Yes.
And many others who are already experts in this area. So we're certainly not reinventing.
And he would endorse that he is an expert with a particular perspective. However, families, educators, school systems, and children are even the better expert.
Yes.
And what we also know, and Dave will speak to this, the data indicates that children are responsive to often peers who are in position with, again, to be able to provide them with support and endorsement around, hey, these are individuals in our community that can be trusted ambassadors. And again, Dave's point is well made. Students identify for other students, you can trust that ambassador. That's somebody you can talk to before the adults in their lives do that. And then lastly, I think that I just endorse the eclectic array of ideas that always come out of the commission that help inform the work that you get to do. So thank you.
Oh, thank you.
Great. So, Kaylee, we've been talking about this for a while now, and I appreciate you lifting up this work and look forward to the recommendations, and I agree with everything that's been said. We've also been looking at universal screenings, and a couple of things have come up, especially as it relates to schools. You had, one of the bullet points was the tension, and Dave's absolutely right. You cannot ask that which you're not going to address, and that is the biggest tension and this especially became an issue as we were coming back from the pandemic, because everybody was worried. We need to be asking what is going on, what are the mental health issues, and then right after that, it was like, and then what are we going to do about it? Do we have the capacity to do anything about it? So having said that, we also know that there are students who, even if we have a mental health professional on campus, they're not going to approach. So what about those suffering in silence? And many are. So through a screening, it's going to be ways that we are going to be able to identify. And many of our students are suffering in silence. So we know universal screenings are our best practice. So how do we do it? So that's what your work is going to lead us to. It's the recommendations and the learning. We also know that mental health literacy right? So it's an and approach. It's a mental health provider on campus. It's the mental health literacy of our teachers. It's mental health literacy of peers, because your peer is absolutely, so it's going to be the learnings, I think, of everything that we've said here, and then informed recommendations. Because we need to build up the whole system of the school, not just a screening tool. We've also have seen, I know I've seen, where we have some districts saying, oh yeah, we do universal screenings, mental health screenings, and they're not mental health tools. They're social emotional learning screening tools. I'm sorry, that is so very different that if I have to say it one more time, my head's going to explode. But that's exactly what it is. So we even set up our students to fail, our parents to fail, because we're measuring things that are not mental health, and parents are expecting change. And so we really have to get this right, because those recommendations are going to change lives and systems. So I thank you for this. I look forward to working alongside with you, because I appointed myself too, so please join me, Commissioner Gordon. That's right, we all get to do this. So again, thank you for that. So at this time, we are going to move forward and have lunch. I'm sorry, no, but we're going to have public comment. I apologize. We're going to move on to public comment, and then we will have lunch. So at this time, members of the public may request to make a public comment on agenda item 7 by clicking the raise hand button on your computer or the app, or if calling in by push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now, as the queue will be closing. Please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item 7.
Okay, we currently have one public comment from Stacy. Your line is open.
Thank you. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I really want to thank Commissioner Roulette, especially for his comments. As usual, I can count on him to say things and bring up things that are very relevant to the people and communities that I serve. I want to say, and I think you may have heard this story before, that I am professionally and personally in favor of mental health screenings in schools. When my son was in grammar school in Sacramento, the school did a mental health screening, I believe on all the students in that grade, which was quite young, something like 3rd grade or maybe 4th grade. I received a call from the school letting me know that one of the answers on his screen might be a red flag, and that they wanted me to know. To make a long story short, I had a talk with my son, and I quickly secured a mental health therapist for him. The therapist saw him for a couple of years, but also had sessions with our whole family. I believe without therapy, very serious issues could have developed for him and our family. My son is now 31 years old and living a happy life in Southern California. So obviously things turned out well. But I do want to mention that while schools are a logical place for mental health screenings and programs, remember that for all students and families, school campuses are not the refuge or welcoming, safe place that they are for others, for many. But this is especially true for some students and families from BIPOC communities, and for some LGBTQ students, especially in rural communities. So while for obvious reasons, I strongly support mental health screenings in schools, please remember that treatment and programs may be better placed at community-based organizations or other places off campuses. And I do hope as this project moves forward that communities of color and LGBTQ communities and representatives will be invited to advise on this project. Thank you.
Thank you, Stacy.
And that was our last public. Oh, I'm so sorry. We have one more from Kit Wall.
Thank you, Mariani. I'm Kit Wall. I'm project director of Words to Deeds, a statewide collaborative changing the paradigm for criminal justice and behavioral health. And we've been together for 20 years. So we've been working in this space for a while, and thanks to a lot of help from the MHS-OAC too. I just wanted to basically have a chance to let you know that the state of Nevada, if you don't know already, and maybe Callie, I don't know that we've met, so I look forward to it, and I'll talk with you one-off. The state of Nevada in 2013 started exploring the opportunity of universal screening for all middle school students as they entered middle school. And similar, again, like, the idea of the universal piece, at the same time, I think students there are required to have a certain number of vaccines and medical exams and so forth before they enter middle school. And so one of my good friends who worked for Medi-Cal then went to work for the state of Nevada. And I followed up with her this week, seeing this on the agenda item. She worked with a woman by the name of Christy McGill, who is now director of the Office of Safe and Respectful Learning Environments for the Office of Education in Nevada. And Lori was able to tell her about this agenda item. And so she offered to speak to, meet with, however she could help with this project, so that California maybe didn't need to reinvent the wheel, or, go through some of the permutations they did. But Clark County, I think, was an initial pilot program. And I think just in looking at news stories, one of the research folks that set that up also had worked with LAUSD and also a couple of school districts in Georgia. So I'm really just offering to put that on your radar, and I'm happy to follow up with you individually, however I can make introductions for you.
Thank you, Kit. We will have Kaylee reach out to you for that contact information.
My pleasure. Thank you.
And that was our last public comment.
Thank you, Mariani.